Welcome everyone to the new second half of the year, or to 2021, which we all hope to be a better year, but to the launch of medicine grand rounds for this year. I feel incredibly privileged to have the opportunity to launch our new year by welcoming Dr. Bill Foege to Medicine Grand Rounds. I will say that highlighting his key contributions to public health internationally in ways that affect the lives of all of us all over the globe is really impossible in the amount of time that you would like to hear me talk in an introduction. So I will say that currently Dr. Foege is the Emeritus Presidential Distinguished Professor of International Health at the Rollins School of Public Health, having joined the Emory faculty in 1997. He attended medical school at the University of Washington. He did a stint as an epidemic intelligence officer at the CDC and obtained his MPH from the Kennedy School. And after that, began working on the smallpox eradication program at the CDC, developing the strategy of ring vaccination or surveillance containment, which was a new idea at the time and allowed this disease to be eradicated with focused vaccine use at a time of shortage. He was appointed by Jimmy Carter as director of the CDC from 1977 to 1983, serving two presidents, then co-founded and served as president of the Task Force for Global Health, which is headquartered here in Decatur. He was also executive director of the Carter Center from 86 to 92, and a senior medical advisor for the Bill and Melinda Gates Foundation, where he played an instrumental role in guiding the resources of the foundation into the research and preventive activities around the world that you see today. As you may expect, he has won many prestigious awards, too numerous to enumerate here, but including in 2012, the Presidential Medal of Freedom, which was awarded to him by Barack Obama. Most recently, he co-chaired the National Academy of Science, Engineering, and Medicine report entitled A Framework for Equitable Allocation of Vaccine for the Novel Coronavirus, so his work stretches to the absolute present. Clearly, this list of accomplishments makes Dr. Foege uniquely qualified to provide reflections on past pandemics and thoughts on the current one using many, many different lenses. But in addition to these credentials, Dr. Foege is a person of unique vision, of profound wisdom and moral integrity, which are attributes that, while always critically important, their presence is perhaps even more appreciated today. So, Dr. Foege, we feel incredibly lucky to have the opportunity to listen to you today. Thank you for joining us this afternoon, and we look forward to the talk, which is entitled COVID-19, Looking Back from 2022. So we will expect you to be clairvoyant. Let me remind our audience that there will be time for question and answers, which I will moderate, so please feel free to enter questions in the chat as we go. And Dr. Foege, let me turn it over to you.
Thank you, Wendy. We have a 5-year-old granddaughter who attends school in Uruguay, where they still have school, and she will not go to the bathroom at school. And when asked why, she says, "I don't want to miss anything." Well, we all have that reaction to an exciting life at times, but after 85 years, I can tell you there are things I would like to have missed. Pearl Harbor being one, the Holocaust another, the invasion of the Capitol, and now the pandemic, but we're faced with them. I'm called on these days not to discuss science, but history, so people see me as having lived through it. And so I'm going to talk about three things today. One, to look at some of the things that have been on the news continuously and try to ask what this means from a historical perspective. Second, to review the essentials of a public health program.
People are really grappling.
And third, to compare the lessons of outbreaks in the past and ask how do they apply to what we're going through now with coronavirus. So first, looking at some of the things on the news and trying to bring a historic perspective to them. Number one, we hear about herd immunity quite often. 55 years ago, I was told that the herd immunity level for smallpox was 80%. If we got to 80% vaccination, we would stop the spread of smallpox. Twice in Africa in the 1960s, I found that this was not true. One was I investigated an outbreak of smallpox in a city that had just had a campaign that was documented as 93% effective. And here I was looking at a smallpox outbreak. So 80% was not adequate. At the same time, I was dealing with an outbreak where we were able to stop the outbreak with 7%. So herd immunity doesn't mean anything without a second number, which is population density, because we're really concerned with how many susceptible people do we have per area. And if we reach 30% protection in Seattle, for instance, we would never regard that as herd immunity. But 90% protection in New Delhi left the same number of susceptible people per square kilometer as 30% in Seattle. So when you look at this, you realize herd immunity is not the place where we should be placing our attention. Instead, it should be to stop the spread of the virus. And so if we look back from 2022, we're going to see that people stopped talking about herd immunity and started talking about what are we doing to contain the spread of virus. Number two, contact tracing. The test results we all recognize are too late to really do very good contact tracing in this country. A friend of ours had 3 people in the family diagnosed with coronavirus. One of them died, but the contact tracer didn't contact them until a week after they had received their test results. And so contact tracing is always looking backwards, and it shouldn't be. It should be looking forward. So that if we were able in January of 22 to look back, what would be the difference? It would be that we took 2 programs that were not working well, vaccination and contact tracing, and we put them together. It would mean increasing federal funds so that 3,000 counties and tribal groups and so forth now had sufficient contact tracers and vaccinators, and that the tracers were actually trained by Zoom by CDC people who do sexually transmitted disease investigations, and that the vaccine would be given to a new group of priority people, which would be people who are getting their test, so that at the time they're tested for the virus, they would be offered the vaccine. And if they took the vaccine, we know that the majority of people being tested are negative, but now we have these negative people with their first dose of vaccine. They are high-risk people, or they would not be getting the test. They either are concerned about occupational exposure or about lifestyle exposure, and they're going to be exposed again. Then the positives would get the news of their positivity, not from the place doing the testing, but they would get the news from a contact tracer. And so you skip one entire step in this procedure and they immediately are talking to a contact tracer. And the contact tracer would not be concerned with the history of what happened 2 weeks or 3 weeks earlier. They would be concerned with who have you had contact with since you've had your test, or 2 days before your test, or 2 days before your symptoms. Always looking forward, where the vaccine is then going to those contacts who are offered testing and tracing. So the vaccine is always at the front edge of the epidemic curve, the transmission curve, rather than going backwards. A third thing that I would mention is that this is going to be labor intensive and people will say you can't do it. So I would remind them of what happened in India in 1974, when there was so much smallpox that even 6 months into the program, as we were perfecting a new approach of surveillance containment, we were still having, in a single state, 1,500 new cases of smallpox a day. That meant 1,500 new investigations a day, finding the people, isolating them at home, putting watch guards on the house for 24 hours a day in order to vaccinate any visitors. So we were talking about thousands of outbreaks at one time. And in each outbreak, you might have a dozen or even 100 households involved. So we were talking about tens of thousands of people. Sometimes we were up to a point of 100,000 people just as watch guards. And this at a time before smartphones or computers in the field. So when people say we can't do it here, I just have to remind them of this can be done. It means thinking, though, in a different scale. It means a federal plan, hiring appropriate number of people, and building the public health infrastructure in this country. The third thing that we hear about on television all the time is hesitancy. And we know the problem. We know the problem of hesitancy. But I was surprised to hear Miles O'Brien report from Atlanta as he was talking about hesitancy and the Tuskegee experiment or trial. That was a problem, but he presented it as a program that was run by the US Public Health Service and CDC. This program, the Tuskegee program, was started in 1932, 14 years before CDC was developed. It ran for 40 years till 1972. When it became public, there were hearings. A task force decided that this was ethically something that could not be continued, and the program was stopped. 3 years later, the Public Health Service in Washington transferred the program to CDC to close it down, to make sure that the participants got adequate medical care, spouses, children all got adequate medical care. So yes, CDC did close down that program, but it did not run that program. And I don't want people to be confused with that. Other pandemics. The smallpox lessons are going to be clear, but we've had many pandemics, and CDC and Emory have been involved in many of them. So it's not just Ebola virus and Lassa fever, but many of them. But I want to be sure before I leave the other pandemics to make it clear that we have a hero in our midst, Gene Gangarosa, who helped change what happened for cholera. Gene is now in his 90s. He's still teaching here at Emory. But when he was young, he doubted the wisdom on cholera, which was the reason people had such severe diarrhea was that the lining of their intestinal tract was so fragile. It was like the burn of a skin, and it was excluding liquids all the time from the body into the intestinal tract. Gene wasn't sure that that was true, but then he did an experiment that even today, I cannot comprehend how you would have the nerve to do it. He went to cholera patients, sick cholera patients, and he had them swallow a small metal ball that had a long filament coming from it. And they would swallow it through their esophagus, through their stomach, into their small intestine, at which time he would put a syringe on this filament and put negative pressure. This would cause the intestinal lining to pucker into a hole in that metal ball, and a small scalpel would cut off the piece of intestinal, so you had a biopsy of the intestinal wall. He would then pull that back out through the stomach, up the esophagus and out, and have it tested. What did he find? Intestinal mucosa was normal. And this led to a search for a way to hydrate cholera patients without using IVs. And this led, of course, to what we now know as the right kind of fluids. Because what they found was it was a problem of getting the sodium and the glucose at the right level, in right proportions, so that the fluid would go from the intestine into the person, and it changed the treatment of cholera totally. Another thing that is discussed is public health and the politicians. And we hear repeatedly these days, we should not have allowed the politicians to be involved in this public health program. I reach exactly the opposite conclusion. We need to have the politicians involved, but what we do not want is to have politicians who are corrupt. We don't want politicians who have no moral compass. We don't want the Michael Caputos of Health and Human Service or the Dr. Atlases involved in the public health program. But we do need the politicians, because the politicians are the ones that provide the resources for public health. There's always been a very close connection. Sam Levinson, the humorist, years ago said, "It's not difficult to be brilliant." He said, "Think of something very stupid and do the exact opposite." And over the months, I've been thinking of how brilliant our public health approach could have been if we had simply asked, what would Donald Trump do? And then do the exact opposite. So we have to embrace politicians, but the right politicians. Public health, after all, is a single payer system. I'm sorry, I don't know. Why don't you take it out? Public health is a single payer system. And so we have to think about, how do we get the good politicians involved? And in Georgia, we now have 2 senators that are very interested in public health. Every outbreak has concluded with the thought, we need to strengthen the public health infrastructure in the future. And so we have asked the question each time, what do we do? In every case, this resolve has dissolved as soon as the problem is over. One exception, and that was after Ebola. And after Ebola, there was a program started in the White House, but it didn't have staying power. The Trump administration halted it. Likewise, 40 years ago, CDC with the FBI had developed a very good program for new organisms and for bioterrorism. It was a model program of looking at every organism and asking, how would we protect against it? We had 24-hour service people on alert. We had safe rooms at CDC. We had a safe telephone system, and it did not have staying power. The next director of CDC dissolved it overnight, simply saying, this will never happen. Now we ask the question, what are the foundation stones of public health? And I think there are 3 of them. One of them, of course, is science. And with science, it is not the same as truth, but it's a method of trying to find truth. It's not the same as certainty, but it's an attempt to come as close to certainty as we can. And Huxley said, at its base, science is simply a common sense at its best. But a second building stone is art. Durant said the first scientist that we know in history was Imhotep from Egypt. He designed and built the step pyramid. And he said this art brings creativity to science. And so you have creative common sense at its best. But the third stone for public health programs came from Roger Bacon 700 years ago. He did a report on science to the Pope, and he was so enthusiastic about science and had so much vision. He actually 700 years ago predicted cars, submarines, airplanes, telescopes. But he said to the Pope, science does not have a moral compass. And so the conclusion was you have to develop scientists with a moral compass. And when you put this all together, you have moral, creative, common sense at its best. Now to the third point, which is the lessons we've learned from smallpox and other outbreaks and how they've been applied with the current pandemic. I go back to something I got out of the New York Times years ago in their Sunday column on Around Town. And they had taken graffiti from a subway wall that said, "Don't confuse destiny with bad management." Smallpox did not disappear by chance. This is a cause and effect world. And Stephen Hawking, in his book, A Short History of Time, says that science, the history of science, is the gradual realization that things do not happen in an arbitrary fashion. They happen because it's a cause and effect world. Coronavirus did not become this bad in the United States by chance. It became this bad because we did not pay heed to the lessons of past pandemics, past outbreaks. What are some of them? Well, the first one is know the truth. If you don't know the truth, you simply tie your hands. You cannot respond in a responsible way. And the way to know the truth is to have a good surveillance system. We've always depended on CDC for the truth when it comes to public health. In this pandemic, we have not gone to CDC for the truth. We've gone to journalists and we've gone to Johns Hopkins. A Cornell Alliance for Science study, which I will quote, found that, quotes, "The biggest surprise was the President of the United States was the single largest driver of misinformation around COVID." Think of that. So know the truth, and we have to get back to knowing the truth and having CDC be the beacon for that. Number two, provide a national plan. In this country, instead of a national plan, we said states will be responsible. And so we had 50 plans rather than a single plan. And in 2021, we're going to look back and know that in January of 2021, in 2022, we'll look back and see it this January, that we finally established a national plan. And that this national plan, I'm certain, will change this pandemic in 6 months' time. Third, develop coalitions. Instead of coalitions, the administration developed competition. So 50 states were competing against each other and driving up prices to get even the most basic protective devices. Another lesson, the best decisions are based on the best science, but the best results are based on the best management. What we have seen with vaccine has put both of these together, the best science and the best management, but that was not used for addressing the pandemic. It was used for producing the vaccine. And now we have to look back from 2022, and we will see that this year we bring that back together. So the two things, the best decisions and the best management, will come together to address the pandemic. Another lesson is to respect the culture. The National Academy of Medicine report made it clear that the problem is not race, it's racism. And so minority populations have more comorbidities because of racism and their inability to have the same medical attention. But in addition, they're in a social situation that has comorbidities. And so they have to go to work. They have to be exposed to the virus. They're living in 3-generation households. There are so many things going against them that it's a matter both of the personal comorbidities and the social situation. And the approach is not going after race, it's going after racism. As we look at how to get the minority populations who are taking the worst beating from this virus and yet have the most reluctance to get the vaccine, how do we get to them? By not being government telling them what to do, but by incorporating the Black churches, the Black medical societies, the Latino churches, by including the people who are able to give good information to the minorities, people that are trusted by minorities. And another lesson, make every decision on the basis of the hope for global equity. I think leaving WHO was beyond understanding. I cannot conclude how intelligent people would be able to leave the WHO, but now we have. And so we've got to quickly restore that global contact. And CDC should be the key to making that happen, because CDC has had a relationship with WHO over the years. Many CDC people have worked at WHO and vice versa. And so I am hoping that very quickly we reestablish our global connections. There are other lessons in all of this. The lesson of avoiding certainty. Richard Feynman said certainty is the Achilles heel of science. And it's the Achilles heel of politics and religion and many other things. But I think the point I want to make is that every lesson that we've learned from the past has been violated by this administration in approaching coronavirus. And we have to make sure that this does not happen in the future. Public health was not blameless. As Primo Levi said, that when you know how to prevent torment and don't do it, then you become the tormentor. And those of us in public health became the tormentors. I don't know all of the pressures that CDC encountered, but I do know that the rest of us were too quiet and should have pushed back. I should have been making this case 10 months ago. But let's proceed with optimism. Ernest Shackleton said, optimism is true moral courage. And Churchill said, an optimist sees the opportunities in every difficulty. So our challenge now is to strengthen the public health and political coalitions to develop mechanisms for public health resilience in the future. And I think a first step might be if our two organizations, Emory and CDC, would invite our two new senators to an Emory CDC seminar to use coronavirus as the way to make the next 6 months most productive for public health and to come up with solutions. Peter Marshall once said, freedom is not the right to do as we please, but the opportunity to do what is right. And finally, therefore, we could use this meeting to do what is right. And with our senators, we could strengthen the public health infrastructure for the future. Thank you for being with me. Thank you.
Thank you so much. That was full of so many lessons that I don't know where to start. I have several questions for you. I've had a couple texted to me. Let me actually ask Dr. Del Rio to unmute and ask you the first question.
So Bill, thank you very much again. Always just a pleasure to listen to you and hear your wisdom. So let me ask you a theoretical question. Had you been the CDC director during this past administration and during what happened and the way CDC was muscled and essentially made non-existent, what would you have done? Would you have resigned? Would you have spoken up? Would you have, call on the public health, service in unison to all resign? What would have been the way of the CDC director to lead appropriately?
Well, I first must tell this audience that Carlos asked me this morning if there was anything he could do to help me. And I said, sure, you could answer the questions. So I could turn this around. But I think the answer to that is I don't know what I would have done, because I never faced the kind of political pressure that CDC faced with this outbreak. I did face political pressure, and particularly when the aspirin manufacturers did not want us to publish material on aspirin and Reye syndrome. And they had such a strong, strong lobby that, and at that time, believe it or not, we had 4 small studies that indicate aspirin was causing Reye's syndrome if used with influenza and chickenpox. But none of them came to statistical significance. And in those days, we did not know how to aggregate studies. So we didn't do meta-analysis. In looking back, I find that the agricultural people were already using that kind of technique. We didn't. And so we worried about what to do because the aspirin manufacturers kept telling us, you're going to make a laughing stock of CDC if you put out something that does not have statistical significance. And we finally decided with the American Pediatric Association, we're going to do it anyway. FDA was going to join us. The night before this was to be in the morbidity mortality report, FDA called me at home and said, the aspirin manufacturers have come up with new information. We have to analyze it before we can sign on. And so everyone assumed we would delay the publication. I went to work the next day and told no one about that phone call. And so we ended up publishing it. And immediately the White House pushed back, and they pushed back hard. But what is different, in those days, my boss, the Assistant Secretary for Health, Ed Brandt, stood behind me. And then the Secretary of HHS, Richard Schweiker, stood behind me. And so the White House directly told me that I should cease and desist. And I said, of course I will, because we'd already published it. There's nothing they could do to actually take it back. So I had those kind of problems with political pressure, but not what CDC encountered here. But my suspicion is I would not have lasted very long.
Dr. Stevens, I see you have your hand up.
I do. Bill, thank you. Really great remarks, and thank you for your leadership and over many, many years in public health and for Emory, obviously with CDC. My question is about the current vaccine rollout and your comments about what we can do differently with a new administration, a new agenda. I mean, it's not gone well. I think we all agree with that. I was curious and interested about your remarks that suggested ring vaccination as a strategy, and wanted to get more of your thoughts about what we need to do differently with the current vaccines and their rollout.
Okay, thank you, David. It would not be ring vaccination in the sense of what we did with smallpox, but what it would be doing is trying to stay ahead of the curve rather than looking at the history of contacts. And if you added then vaccine to every test, you're quickly getting the high-risk people with vaccine. And of course, these days with computers and smartphones, you can actually sign people up and get back to them for the second one and so forth. But I think a big gap has been this one between the testing and the contact tracers. If it takes a week after the positive test comes back before you hear from anyone, that's not very effective. It's not very efficient. So I see the Biden administration putting in the same sort of resources that were put into the vaccine production, and that these would go out to the counties to hire the people that are needed for both contact tracing and vaccinating. And see, vaccinating is not brain surgery. It doesn't take years in order to train people to do that. We have so many people that give injections all the time. And so I am starting from the point of believing we're going to have enough vaccine. I think it's going to come out very fast. And we don't know this, but when Johnson & Johnson comes out in the next few weeks, we may suddenly have much more vaccine, and it will only require a single dose, only require refrigeration. So I'm starting with the hope that vaccine will not be the limiting factor, and that we get it to not only the high-risk people, such as the seniors, but also the high-risk people who are right at the cutting edge of transmission. So it's not the same as ring vaccination with smallpox, but it's a similar idea of going after the virus and becoming clever enough to evolve faster than the virus does.
So along perhaps those same lines, a question was asked, what do you think about the decision to release all doses of vaccine that was mentioned in this past week and hope to have enough for the second dose within now, that would be within a 3 to 4 week window or perhaps longer, as part one. Actually, I'll give you that first.
Of course, this is a question that's very easy to get on the wrong side of it. But if there was not a lot of vaccine coming down the pipe, then I can see the reason to hold back so that you have enough vaccine for a second dose and to adequately protect a certain group of people. But if you start from the point of view that you're going to have enough vaccine, I think that it would be a mistake to hold it in the refrigerators when it could be in people.
And so as a sort of second part to that, I've heard there's been a lot of discussion about how trying to be very strict with the tiers has actually led to more of a delay getting more vaccine into arms by kind of being sure you have the right people in the right tier. But and so some advocates to really just starting to vaccinate a little bit more freely, with the opposite side of that coin being that if vaccine is more freely available, the people who may not get it are the folks who have less access to health care and perhaps are higher risk groups and minorities and so on. Do you have any comments about that?
There are lots of problems here, and the National Academy looked at one program doesn't fit everybody. For example, if you went to a village in Alaska, it would make no sense to limit your vaccinations to elderly people or people with comorbidities. If you're there, you're going to vaccinate everybody. And the same thing with American Indian tribes. So what is the best approach, I think, is to have a national plan, and then states are able to modify that according to their own states. For instance, not every state has chicken production or pork production facilities. And so you have to alter it according to what are the priorities in the state. But I think to have a national plan and then allow a lot of flexibility to states and counties is the right way to do this. And I appreciate that it's been chaotic in many ways. It's surprising that it is this chaotic. It's not as if we don't have plenty of history on how to do immunization programs. We do. So I think part of the chaos is we don't have the infrastructure at counties that we need in public health. And so this has been due to a starvation of resources for some years. And we've got to get that back. That's why I suggest we have a federal program with a lot of money being paid to bring counties up to what they need for contact tracing and vaccinating.
Dr. Smith, you have your hand up.
Yes, first, just for those who have not seen the Emory 2016 commencement by Dr. Foege, you should search YouTube and watch it. I've probably watched it about 10 times. It's fabulous. Dr. Foege, a question relates to how this situation became so politicized and how the public reacted to things. I was in Blairsville, Walmart this weekend, and probably a third of the people in there did not have masks. I guess part of this was that early on when things shut down, that people really felt like their jobs were at risk, and that the government was, putting their financial livelihood at risk. Could you comment on that and just
The, the, the question is a tough one because we have watched what's happened with the anti-vax people over the years. And it's surprising how people will not listen to authority, but they will listen to rumors. And so when I think of Andrew Wakefield being able to put out one paper on—
Sorry about that. I got cut off, but just the question of that people really fearful for their jobs and therefore viewed government negatively. And had you run into that type of situation and other things that you handled around the world, and what lessons might we learn, and what did you learn from other things you did around the world?
Thank you. I mean, this is clearly an extension of the lessons we've been learning in immunization, where people turn against vaccination. And at one point, my wife and I lived on Vashon Island in Puget Sound, which had some of the highest rates of non-compliance on vaccination, to the point that the New York Times actually had a front page article. And I think at that time, 18 or 19% of the children on Vashon were not getting immunizations. And it's an interesting thing that people are so resistant to listen to authority, and yet they'll listen to non-authority. And so when Andrew Wakefield would put out one study in Lancet saying that the measles, mumps, rubella vaccine could lead to autism, people have stuck to that. And even though it was shown that it's not true, and there have been many studies that show that there's no increase in autism with childhood immunizations, he lost his license, of course, in the UK, but he came to the United States and he continues to give talks. Why? Because if you have an autistic child, you want an answer, and he gives an answer. And so many people are looking for an answer, and these theories somehow satisfy them. So it's a very difficult thing. What we found on Vashon is the government could not come in and change people's minds. But there was a couple on Vashon, they former Peace Corps volunteers, who began a grassroots program of asking parents, what do you need in the way of information to actually make a decision? And they were able to change this. The last time I looked, the non-compliance rate had gone from 19% down to 12%. So they were having an impact that government could not have. On the current coronavirus series, what Cornell showed was the surprising thing, that the major source of misinformation was our president. People were listening to him. And so he obviously has an authority that's not always shared by the rest of government. And we have to figure out how to get people trusted to speak to minorities and other groups, to allow them to know what is the truth. How do you find the truth? And in some ways, it's becoming harder to find the truth because of the easy access of information. I'm also impressed with the fact that when nuclear weapons came on the scene, suddenly we saw what asymmetry could do. At one time, if you had a war, the winner was likely to be the person with the most troops. With nuclear weapons, we suddenly realized that a small group of people could hold lots of us hostage. The same thing with bioterrorism. A small group of people could hold us hostage. But now we're seeing it with politics, that a small group of people can hold us hostage. And so there's no response except to get people of goodwill. And that's why I suggest we get our 2 senators to Emory and CDC, because they already believe in public health. Find out how to get this public health, political, intertwined approach back to full strength.
That's critical. Dr. Steinberg, you have a question.
Thanks very much for this fantastic talk. There's been a vigorous debate about use of some tests which have maybe lower or may not be as accurate, lower fidelity, performance characteristics aren't as good, but have a very rapid turnaround time. You were telling us some of the barriers to effective contact tracing strategy and the turnaround time of tests. I'd be curious about your impression of use of some of these rapid tests that may not be quite as accurate, but would speed turnaround time and their utility for going forward to help curtail this current outbreak.
Well, Carlos is a much better source of information on that. I've been impressed with how much of our testing is probably just spinning our wheels, that it does not give us a good answer on what's happening. It has to be repeated. It's not useful for contact tracing and so forth. But I would bow very quickly to Carlos to answer that question.
I mean, I think that we've done a lot of testing, but I don't think we've done necessarily the right testing. I think we continue doing testing as primarily a diagnostic testing, and we're doing that in hospitals and in clinics, but we're not using the testing in a public health way the way we actually should. And we're not doing good testing for both surveillance or for, screening. And I think we need to scale up screening and testing very, very much. It's unfortunate that the government paid millions of dollars to buying the Binax now tests, which are not bad and should be used more effectively. And most of them are still in warehouses. They send them out to the states, and the states essentially have them, in storage facilities as opposed to deploying them to be used in schools and businesses and many other places. And I think we really, again, have failed to deliver the testing the way we needed to. I mean, would have been really nice to have that kind of testing available, but we're still trying to rely on PCR testing and on clinical diagnostic testing to try to do surveillance. And that has just overwhelmed the system. And as you say, Bill, has just basically, created spin our wheels, because, we're screening, doing PCR testing, PCR gets delayed, then we get the results 4 or 5 days later, maybe more. It's of no value, where you could do multiple rapid tests and get a result that will tell you at least if somebody's positive or not.
I want to shift a little bit to a different question. Dr. Talbot, you want to unmute?
Hi, thank you so much for your talk. I just had a question since you had mentioned the staying power of national programs. And so considering that we've seen a lot of rise and fall in public health programs at these national levels, there's lots of different interests, such as, Zika virus, we have PEPFAR, all of these different funded programs. Some of them stay, some of them don't. But what are some of the ideas that you have about encouraging public health professionals that have some background or some ideas about evaluations, especially of things like surveillance systems, and getting them involved in this evaluation process to help these programs stay relevant and be flexible and increase their longevity, so that we can continue to learn from our past experiences with a lot of buy-in from politicians and from the public health professionals themselves.
Okay, I had a little trouble hearing that, but I think I got the gist of the question. One of the things that we did in India in the endemic states is we actually had a meeting every month of the key workers to find out what worked this month and we should strengthen every place, what didn't work and we should drop. And so we need the same thing in public health as I have in business, of continuous evaluation and learning and improvement. But another thing that I keep saying to young people, if the tie between public health and politicians is so strong, we should be encouraging young people in public health to go into politics. It's a much more efficient way if we get public health people into the political positions rather than having to retrain politicians all the time. I go back to when I was director of CDC, and I would sometimes become very upset about a political decision. And one day when I was particularly upset, my deputy, Bill Watson, said, "Well, it's all your fault." And I asked, what do you mean? And he said, if you had just anticipated what the politicians needed to know before they made that decision, they wouldn't have made that decision. And so I then went into a second phase of evolution of trying to provide information to politicians. It turns out to be very labor intensive because they keep turning over. They may not have that much interest in public health. And so I finally got to this third point in evolution of saying public health people should be going into politics. We should have as many public health people as we have lawyers in Congress and see what happens then.
A great thought. Dr. Rollins, are you able to unmute and ask your question? If not, I can ask it for you. Professor Rollins was asking, you've talked a lot about appropriate contact tracing. When we have an epidemic with the amount of spread that we already have, is contact tracing even feasible at this point? And should all resources be directed just into vaccinating the vulnerable?
I think it's absolutely feasible. And I go back to my India example, which if you can imagine having 100,000 people just as watch guards, I mean, that's an enormous program. And if you think in terms of staying at the cutting edge of the spread of this, rather than trying to go back and reconstruct all the history, where did you get your virus and so forth, but no, who did you give it to? So that with the contacts, you go to them immediately and you try to find out who did you contact 2 days before you had your symptoms or 2 days before you had your test. And from that point forward, and you immediately contact those people and get them tested and vaccinated. Then I think contact tracing is not only feasible, but it is the fastest way for us to bring down this epidemic. I freely predict that if we actually implemented this in 3,000 counties, we would be able to bring down the COVID-19 rates within 3 months. And I think at 6 months, we would see an enormous change. At that point, we would have 3,000 counties with a strong infrastructure, and even importations would be quickly diagnosed and handled. So yes, when people ask, but isn't this too big a job? You know, all of these jobs break down to little pieces. They have to be done in each community. And so it isn't as if a person in Washington, D.C. has to do everything. You have to come up with a plan that works and then get every county to actually implement that plan.
We have like 3 minutes and I'd love to get 2 more questions in if I could have an extra minute or so of your time. The first is, if you were the new, Dr. Walensky will start as the CDC director on January 20th. What should we look for in the first 30 days? What would you prioritize if you were stepping into this situation in that very first short period of time in that job?
First of all, I would enjoy being the oldest director of CDC ever, but I would be trying to get Congress to appropriate an amount of money that allows you to restore the infrastructure at every county level, because I think that's what's holding us back. I think that's what's leading to chaos. And I think it would also cement the relationship between CDC, states, and counties. This has historically been one of the unique parts of our government, that is the relationship between CDC, states, and counties in public health. We have so many people from CDC, including myself, assigned to states. And I was assigned to Colorado, and I took my direction daily from Colorado, not from CDC. And so I was able to see this from both directions. And there has now been a rift in that caused by this administration. But CDC could quickly change that. I at one point thought it's going to take years for CDC to get its reputation back. But I think it could be done very quickly if CDC became the conduit of a public health program in every county, that they would see that CDC was working for them. So I think that would be my idea, to get money to the county to actually be able to carry out a federal program.
Great. All right, I'm going to close. Dr. Steinberg has a question that I think is an appropriate sort of closing question.
Thanks, Wendy. One thing that dawned on me during your talk is how you weave in storytelling and personal anecdotes. And I think part of the power of your amazing ability to communicate is your weaving in of stories. And I would just appreciate your thoughts on the value of storytelling, especially for a scientist.
Well, storytelling is everything. The history of everything is made up of little stories all coming together. And if you read the latest Eric Larson book on Churchill's first year, and the stories, one story after another, telling you what were people thinking in Berlin at the same time, what was Churchill thinking in London. And you see how everything connects. So I urge people to keep a journal and remember these stories, because that's what history is about.
All right, we are at the top of the hour. I want to thank you so much. This has been really a wonderful, incredible hour for us to spend. I think there will be many people revisiting this on video, as well as new traffic to your graduation address, which was phenomenal and one I have also never forgotten. So thank you so much for spending this time with us. We are incredibly grateful. And I will see the rest of you guys next week.
Thank you, Wendy.